How is it that you can study so hard and yet not understand the question that's being asked? I've started with my current class preparing for their national exams. And there's a general anxiety because they know no matter how hard they've worked, it won't necessarily translate into a good score on the exam. And the answer to that is this: it's a clinical exam, which means you have to be able to take what you've learned and say, why do I need that in patient care? And it gives you surprisingly different uses than when you're memorizing it as facts. Before we dive into it though, if you're a medical student and you want to learn how to think like a doctor, be sure to subscribe. Every week I do a new video talking about how you can be better in learning how to think like a doctor and organize your data so that it's usable in clinical vignettes. I'm Dr. Philip Tisdall. I practiced general pathology for decades. Over the past 12 years, I've been teaching full time. And I must say, all I dream and think about now is, how do I teach you to be able to do what all of us practicing doctors can do? Because that's how you do really well in your exams. You have to be able to take what you've learned and say, why do I need that in patient care? And it gives you surprisingly different uses than when you're memorizing it as facts. So I'll give you an example from teaching this week. We were talking about congestive heart failure, and that was fine. I went through the standard discussion. It's a good discussion. But then I wrote multiple choice questions that were deliberately squishy, meaning they didn't have really hard facts like what's the capital of Canada. It wasn't like that. It was, so here's the patient. Tell me why I see this. And the question that I really enjoyed was, we talked about how the pressure backs up from left ventricle all the way to the lungs. And when it's more than 20 millimeters of mercury, you get pulmonary edema. Everybody knows that. But the question I asked was to walk me through the pathophysiologic sequence. You had to get the sequence right. And it was surprisingly hard. And I was surprised because this is what I hadn't realized. Everybody does their blood flow from right ventricle through lung to left ventricle. But when you have heart failure and it's congestion, you actually do it in reverse. It goes left ventricle, backs up into left atrium, backs up into pulmonary veins to capillaries, and then the transit into the alveolus, which is easy for me. I've done it a million times. But I was trying to think, it's exactly like doing the alphabet. Everyone can do the alphabet forwards. You don't get any points for that. But just right now, try it. Try going backwards. You realize how awkward you are. And so that's the difference between knowing the letters of the alphabet and being able to use them. And, if you're a native English person, I say, what are the vowels? Well, A, E, I, O, U, and sometimes Y. Everyone can do that. But if it's your second language, you might not recognize that's kind of a common thing. And so to you, it's the first time through and you have to hunt and peck, and then the exam gets long and you miss the last 4 questions in your block, which is easily the commonest way people lose score points. So I've started thinking a lot about, you have to be able to have a really clear way of thinking of your pathophysiology. Yeah, that's great. No, you got to do that. But then you've got to be able to read the question. It's a clinical question. And here's a mistake it's an innocent mistake. I get it. It's because you think it's the old question, in which somewhere hidden in there is, what's the capital of Canada? No, it's not. It's a conversation. I tell students all the time, you should imagine I'm your senior colleague and we're in the ER and I'm telling you something. Hey, I got this 60-year-old lady. She's short of breath. It's been getting worse for months. Go in and take the history and physical, come back and tell me what you think. That's a clinical question. And that sure felt different than hunting and pecking for what country you're in. Are they asking the capital? So what I thought I'd do today is, I want to introduce, first of all, this idea of exams. And then I thought I'd just go through a really standard question. I just wrote out a really common one. And we'll go through it and we'll talk about, how do we think about clinical questions? And here's just the truth. I talked to the school a lot about this. You can't teach yourself pathophysiologic reasoning. You really do need tutoring. And, I felt really bad after the discussion because everyone floundered around in what I clearly thought were very straightforward questions. And so they could tell I was like really surprised they couldn't do them. So they felt bad, and then I felt bad that they felt bad. So it was not a happy day. And I was talking to a really excellent student that afternoon. And I thought, okay, this will be really easy for Mr. Marvelous. Well, Mr. Marvelous wasn't any better than anyone else. And I said to myself, learning your first aid perfectly doesn't give you clinical reasoning. But here was the thing. When I sat down with him one-on-one and I walked through how to order these facts for this very important path of his, he only needed to hear them once. So I'm not saying this is really hard to do, but I'm saying it's really hard to do for yourself. It's especially hard. I'm sure none of my students are going to do it. They all love what I do. They all appreciate how important it is. Oh, they all agree it's way better. And I promise you, none of them are going to do it because they're writing their final exams in 4 weeks and they've got all of undergrad and 2 years to get to this point memorizing. No one full of anxiety is going to do a major change in mental approach if they only have 3 or 4 weeks to go. So I hope you have more than 3 or 4 weeks to go, because I'm going to give you a sense of what it looks like to do pathophysiologic reasoning, which is all of medicine, basically. So here we go. I've got a nice multiple choice question written out for you, and we'll just sort of talk about what pathophys looks like. So here we are with a standard multiple choice question, and I want you to see how I treat this as a conversation, all of which is based on basic medical sciences. So let's just dive in and take a look at it. Whenever we start our story, we always start with see the patient. And by that I mean we're talking about prevalence. So predictive value positive is proportional to prevalence times sensitivity. So sensitivity is of 100 people with the disease, how many test positive? Got it. All our testing's really good now. It's all about 95%. We're not going to talk about that. Let's talk about prevalence. That says if you have 100 people, how many have the disease? And here's the deal. The more you enrich that population, the more likely you are that it will test for the disease, right? So let's just write this down. If you haven't got this in your head, predictive value positive is proportional to prevalence. All diagnosis is based on that. When you're reading the story, get the prevalence right. And we have to do prevalence in 2 different ways. One is what I call the constitutional or fixed prevalence. I'll show you that. And then you got to have a quick peek at the chief complaint differential. And then you say, what are all the stories they give you within that are going to change the likelihood in the differential diagnosis? So let's dive in. We always start with age, gender, time frame. I don't care where you are or who you are or what you're doing. You always start with that. Let's talk about what that means. There are 3 that are just really important. Over 65, middle-aged women, under 25. I'm just telling you, if you just get that in your head, everything becomes easier. Over 65, you've increased the prevalence of degenerative and cancer. Middle-aged women, much more likely to have autoimmune disease and endocrine disorder. When you get into practice, you're going to be convinced that every middle-aged woman has thyroid disease. And then when you're under 25, hereditary congenital. Does it have to be? No, it's how you enrich prevalence. Next, you go to gender. And that's pretty straightforward, right? Women, female reproductive, men, male reproductive. But atherosclerosis is so common in our Western culture that your risk for that is actually baked into gender. Women have this 30-year lag when they're being protected by estrogen, so they start that atherosclerotic curve 25, 30 years behind male. So women -1 atherosclerosis, males +1 atherosclerosis. You'll often see you include the site of service. That actually isn't a big prevalence changer. It's a colorizer. It gives you a sense of how severe, how urgent is this. If someone's gone to a miserable ER to sit in those queues to get treated, you know that they're really quite worried. If they go to a doctor's office, it must be much more casual and chronic because you had to make the appointment, you don't get in for a week or 2. That's a different flavor of the urgency and severity of the symptoms. And then you'll see, oh, look at that. Now we have a chief complaint. And you know, Appendix A in the book has the 50 to 60 chief complaints you got to be able to do at the end of second year med school. So you're always looking for them because they're really common. Shortness of breath, chest pain, abdominal pain, they're very standard. But what that means is anytime that you have a chief complaint, it means that you can form a differential diagnosis. And that goes to the absolute heart of diagnosis. Age, gender, then you've got to be able to do what is time frame. And remember, when we talk about time frame, it varies by organ. So you got to have a quick little peek at the chief complaint and decide what organs you might be in. Because this is how it works, right? Liver is 6 months, kidney 3 months. Okay, what about joints? Someone presents with a sore joint. What makes it acute or chronic? And the answer is 6 weeks. Well, what about diarrhea? Kind of awkward here, right? Less than 2 weeks is acute, more than 4 weeks is chronic. So we got that little ugly gap. Yeah, that's for practice, not for you. So that's not going to come up at the medical student level. And when we get to heart-lung, that's about a week. So shortness of breath, we know right off the top our differential's heart-lung. So 3 months makes it chronic. So look at the power I've imposed on likelihood of disease just by saying old, female, chronic. I've got my chief complaint. This isn't a lesson on differential diagnosis, so I'll just tell you what it is. Remember, differential diagnosis goes by organ, family of disease, as many subfamilies as you need till you have a diagnosis. You notice what it is not. You don't get your shotgun full of diagnoses and shoot at the wall and get a spray of 1,000 possibilities. It's very orderly. Organ, family, subfamily, diagnosis. So I'm not kidding when I say shortness of breath starts with heart, lung. So now I've got my chief complaint. That's going to be shortness of breath. Differential diagnosis, that's by organ system, right? Heart and lung. And now we can do our subfamilies. Yes, you do really have to practice this. When I say what heart disease is going to give you shortness of breath, the answer is left ventricular congestive heart failure. Are there subfamilies? Sure. If you're in America and you say, what are the commonest causes of heart failure? 80% will be due to ischemia, hypertension, and an abnormal valve. Well, you notice that still hasn't got to a diagnosis. That valve could be aortic or mitral. Still haven't got to a diagnosis. It could be aortic regurg or aortic stenosis. Still haven't kind of got to a diagnosis because aortic stenosis could be calcific or bicuspid. So you can see how we work our way down the possibilities. But you notice once we do that, then we can start looking back at the risk factors. Okay, lung. Lung is going to be obstructive or restrictive. And now we can follow out their subfamilies. So with that in mind, we come and look at our diagnosis and say, what else have they given? When you're in your first 2 years, nothing in the stem is going to be irrelevant. You don't have to go searching through the weeds to find the pearls. Everything there changes prevalence. You just got to say, what's my differential? Does it rule it in or rule it out? So let's talk about our risk factors here. Smoking. When I say smoking, how do you organize the pathophysiology? Because if you can't, it doesn't help you very much. Well, here's how I do smoking. It affects the circulatory system. We have to break that out. It causes the number one cause, a risk factor for 5 cancers. Do you know what they are? And it affects the lung, both cancer and COPD. So when you say smoking, that's a very big deal. But you notice it's not going to help shortness of breath. Heart, lung, there's heart, there's lung. So that's not going to be very useful in the differential. We come to hypertension. Can you do hypertension? Well, hypertension is going to be all circulatory. Yeah, guess what? How do you think about the circulatory system? You can't just say circulatory because it has different diseases in different segments. So when I say circulatory, I mean ascending aorta, abdominal aorta, muscular arteries, that's our dancing man. Don't have the dancing man? It's a tough list to remember. And then you've got to go to arterioles. Totally different pathology, right? High-line arteriolosclerosis. And that's the family of macrovascular disease. You just got to see it in your mind's eye and walk through it in your differential rule in, rule out. And then last is diabetes. How do you think about diabetes? Because everyone always forgets acute. Complications of diabetes, acute and chronic. And when I say acute, that's DKA and HHS. We could stop and talk about that, couldn't we? Not applicable here because this is 3 months. However, we have to talk about chronic. How in your mind do you organize the chronic complications of diabetes? And the answer is, macrovascular, microvascular. And you have to be able to talk about that because that's where you're going to go looking in details of your history and physical exam. So when I look at this story, smoking, hypertension, diabetes, I get heart on all three. So that's pretty good. I only get lung for one. So I'm betting heart, not lung. Doesn't mean it's not lung. I'm just saying the weight of the evidence. Except you notice I left something out, didn't I? I left out this, because that's not a risk factor. A risk factor says, what is the relative risk of having this added to your population? This is actually part of the pathophysiology. Cool. Because what this says is, when I lie down to sleep at night, I wake a few hours later with this terrible sense of drowning. People truly fear and hate it. It is a terrible feeling. And they quickly figure out they have to solve the problem. And you know what they do? They prop themselves up. It's such a mandatory part of their life, they don't think about it anymore. So if you say, are you sleeping well at night? They'll often say, yes, I am. Yeah, well, you've got to understand, this is paroxysmal nocturnal dyspnea. This is part of the pathophysiology. You've got to ask for it. It's part of a directed history. You say, oh, are you sleeping with pillows? Yep, sleeping with 3. Okay, well, that's not normal sleeping, okay? So it's not a risk factor. It says this is one of the things that induces and is proof of congestive heart failure. So when you say, how does that work as a test? If I just took PND, we sort of said, how do you think about its value? You're always going to break it into sensitivity and specificity. Well, look at how powerful this is. You only find it in about a third of your patients, but it is greater than 90% specific. So it's something you know to go looking for, because if you have it, nothing predicts that it's congestive heart failure better than that. So let's take a look at our history now. Age, gender, time frame, chief complaints of differential. In the differential, we now go into rule in, rule out, and we differentiate findings that are part of the pathophysiology, really specific, and findings that are risk factor, make things more likely. So based on this history, I can with perfect confidence tell you this is left ventricular congestive heart failure. A lot of talking over just like 2 sentences, isn't it? A lot of thinking. And so it gives you a lot of sympathy when you poor students, having memorized your first aid faithfully, are thrown into the pool and said, well, put that all together. Yeah, it's not straightforward. And I got to tell you, it's what I spend most of my days thinking about, which is, what have I taken for granted that I have to actually stepwise walk you through? And obviously it starts with having a good pathophys. Okay, that's all well and good. Now you've got to say, okay, that's the stem to my multiple choice question. Do you see how many questions I can make from this? So we've talked about this before. The universe of medicine is presentation, pathophysiology, and natural history. Natural history means what happens if we do nothing? Because all treatments have side effects. So your treatment has to have a cost-benefit analysis that's positive. When I say presentation, I mean symptoms, signs, your physical exam, and testing. When I say pathophys, I mean the mechanism of disease. But when I say natural history, and this is very hard when you're just studying from a book, you have to imagine you're talking to your mother's best friend. You've got to be able to explain what's going on, because when you say you have congestive heart failure, she's going to say right away to you, what happens to me? Well, that's prognosis. When you say, well, what are we going to have to watch for? And this is where all my students plowed out this week, because I just sort of threw in there, now she has edema, what happened? And none of them had thought through natural history that left ventricular failure leads to right ventricular failure. That's how I learned none of you can go backwards in your anatomy. So the complications of congestive heart failure would be arrhythmia. And now I'd stop and say, what's the commonest? Well, if you haven't studied it, it's kind of hard to know it's AFib. And then we say thrombosis. And now we're going to stop and say, oh, really? Does it thromboembolize? Well, then we get into long discussions of where does it embolize to, which is its own universal discussion. And then so you do prognosis, what happens to me, complications, things we have to look for. And then, of course, what they really want to know is, are there any treatments? And now we get into this deep discussion of maladaptive remodeling, because that's the cornerstone of treating congestive heart failure. So you can see from this little stem, I can ask any question I want. And in all fairness, I got to tell you, I miss lots of questions. And the commonest way I miss questions is I answer the question I wish they'd ask, not the question they did ask. It's really easy to do because you feel so good about your answer. And so what I do is when I've read the stem, I always stop. I look away from the page. I break intellectual contact and I consciously say to myself, are they asking about presentation, pathophys, or natural history? And then I go back to my stem. Because otherwise I'll just make up the answer I wish they'd asked. You know, they should have asked that. Well, they didn't. You got it wrong. Here's a stem, and you can see it's driven by this idea of fixed prevalences, age, gender, time frame, differential diagnosis driven prevalence, risk factors, really different than if there's a piece of the pathophys in it. And then you tear yourself away and you say, okay, are they going to ask me about presentation, pathophys, natural history? And you go read the question. If you take anything out of this long-winded discussion, it's this: age, gender, time frame. All the rest is great. There's no question. It really helps. But don't miss that point. Age, gender, time frame. Then you won't pick some dumb answer for a 5-year-old and your patient's 55. Age, gender, time frame. So that's how I write my questions. That's what a clinical question looks like. And I hope you find this helpful. Let me talk about why I've written some multiple choice question banks. First of all, I have to. All of you are all tested that way. Do I like it? No, that's a whole different video why I think they're a problem, but here we are. I know that you demand them because that's how you're tested. The problem that we have with so many of the multiple choice questions is they're written so that students can be ranked, meaning strong students, weak students. That's really valuable for the system. It's not valuable for you. You want to know, have I mastered this material? So what you need are teaching questions. And so, with growing frustration dealing with everyone else who can sort all the students out, I'm going to start writing questions for the Pathophys book that are all saying, do the question. If you can do it right, then you understood the point of that part of the book. Just so that you can get a sense of what those questions look like, we've made available 12 very standard clinical type questions. Go give them a try and see if you can appreciate the difference between a clinical question and a standard ranking question. You can click the link in the description. As well, you can click the link to purchase the second edition of the Clinical Pathophysiology book. Thanks for listening. We'll see you next time.